Welcome to this concise video log on caring for a menopausal woman with HIV and a minor fracture. This program is provided by Clinical Care Options and is supported by independent educational grants from Gilead Sciences, Merck Sharp and Dome Corp, and Vive Healthcare. This vlog was recorded by Professor Cristina Mussini. Please note her disclosures on this slide. This vlog is part of a comprehensive educational program on caring for aging patients with HIV. You can gain CME, CE, or CPE credit for viewing these vlogs and download the slides by visiting our website, clinicaloptions.com.
Hello everybody, I'm Professor Cristina Mussini from the University of Modena and Reggio Emilia in Italy. I've just seen a patient who really represents a challenging type of case that I often encounter, and I'm going to go through some of the details of this case. So our patient is Elena. She's a 43-year-old lady who was diagnosed with HIV in 2015. As you can see from the numbers, her viral immunological situation is pretty stable because her CD4 count is 685, while her HIV RNA is undetectable. These results were obtained with a treatment that she tolerated very well, with rilpivirine, emtricitabine, and tenofovir. And now she's in early menopause. As you know, the vast majority of our women go to menopause very early. And we don't know if there is a direct link between HIV and menopause because data are conflicting. But this is something that we very often see in our clinical practice. She is not overweight, she is normal weight because her BMI is 23, and all the other, exam are negative. Also the HLA-B5701, so we have also the possibility to use abacavir. What's happened? Why she came to my attention? Because in January, before COVID, she was skiing and suffered a fall while standing. So a very minimal trauma. There was also the snow, so it was not really a hard fall, let's say. But she had a fracture of the right wrist. Why we have to care about fracture and, osteoporosis in patients with HIV? This is not only HIV. I have to say that if you look at this graph that shows you the bone loss, this is age-related, but this mostly in women, because it's true also in men, but as you can see, the decrease is very stable. I mean, it's a slow decrease, very consistent, but in women, when there is the menopause, the decrease is steep, either in hip or in the spine. And this decrease in bone mineral density is also, connected to a higher risk of fracture that in women happen earlier than in men at a higher degree, higher percentage. And this is true for the wrist. And we are talking about a woman that is in her 43, so she would be here. But also the spine, that it's increased. We are not talking here about HIV, okay? We are talking about the general population. We will see that in HIV, the picture is even worse. While, the hip really increases a lot when either women or men are much older, because it also goes together with sarcopenia and the difficulties in walking and the frailty in general. So when we talk about the women, we said that the rate of bone loss per year after 35 is about 0.51% per year. But women, as I said, have a very accelerated rate of loss after menopause, with a lifetime fracture risk greater than 40% for those older than 50 years. Fragility fracture occurs from a fall from standing height or less and is a strong predictor of a future fracture. So before I was talking about the general population, but when we talk about HIV, it's better to have a look at the EACS guidelines, for example, when they talk about screening and diagnosis of bone density. We are talking with Elena of a postmenopausal woman, but this is true also for men, you know, and when they are older than 50, we have to evaluate the bone mineral density. The bone mineral density should be evaluated with using the DEXA scan. And we have to consider that the two parameters that are shown in the DEXA scan, they are the T-score, but this is the one that should be used in women or men who are older than 50. We are talking about osteoporosis when the bone mineral density T-score is equal or below 2.5 at hip, femur, or lumbar spine. While in the premenopausal period, women and men, if they are aged less than 50, we should consider the zeta score, that should be to diagnose osteoporosis, equal or less than -2, and a fragility fracture. I have to say that the fragility fracture wins on every score, because it means that the bone quality, you know, that it's not the bone density that we see with the DEXA scan, but the bone quality is not good, because this woman really had a fracture from that is a fragility fracture, okay? When we look at the risk factor, we have to consider that there is not only HIV, but HIV is per se a risk factor. We have to consider also treatment, because she is using tenofovir diproxyl fumarate that has been shown to damage the bone, and she is in menopause. So these are three very important risk factors. She is also smoking. She has promised me to quit smoking, and this is very important. But since she is not overweight, she doesn't feel that she needs to have a very routinely exercise activity. She's very busy because she's an accountant, so everyday schedule doesn't fit, the possibility to have a regular exercise. Okay, so obviously these are the criteria for us for a DEXA scan. But as I said, our woman, she already had a fracture. So the DEXA scan will add something, but it's not absolutely fundamental. She is not on oral glucocorticoids, so she doesn't have to stop them. And, it's important that we do a sort of baseline bone situation, okay? So we performed the DEXA scan, and it shows a zeta score less than 1.5 and a T-score -2. So she is actually osteopenic, but the problem, as I said, is that this is the bone density, while since she had the fragility fracture, she already should be considered osteoporotic, as osteoporotic. The zeta score, if we have to explain what it is when the BMD that we obtain with the DEXA scan is compared to the BMD of an age, sex, and ethnicity match reference population. And it's this one. And it's the one that we use for younger women, okay? The younger population. The T-score compare the DEXA T-score to the BMD of a young adult reference population, okay? And this should be used in menopause, okay? Osteopenia is T-score between -1 and -2.5. Osteoporosis is T-score -2.5. As I said, she should be considered osteopenic, but she has a fragility fracture. So this just moved the things a little bit further. And is this something that is rare? As it happens for many things, not only in HIV, if you don't look for it, you don't find it. This is a study that has been conducted in Italy many years ago, actually, almost 10 years ago. But it is a very important one. Those with HIV, those naives and the controls, if you see they look at the spine with the morphodynamic X-ray of the spine, looking for fracture. And look at the percentage of patients who had a fracture, a vertebral fracture, in those who are art experienced, like Elena. We see that about 30% had a fracture. And this is not present in these slides, but I can tell you that half of them had a normal DEXA scan. So it's important to think that vertebral fracture are there even if we don't see them. We don't see them because we need to look for them. So not only DEXA scan, but also the X-ray of the spine. So she had a fracture. We decided that it was better to start for a certain period with alendronate, 70 milligrams per week. You know that there's a problem because she's very young, she's 43. Starting with alendronate, you can continue it only for 5 years because she is, after 5 years, you have an increase in the jaw fracture, spontaneous jaw fracture that is linked to alendronate. So it's at least we started and we will see what happened. But obviously the first decision was to discontinue tenofovir diproxil fumarate. The choice could be between a dual treatment with 3-TC plus dolutegravir and a TAF-based regimen. If we discontinue tenofovir diproxil fumarate, what happened to the bones? What we see, these are two studies, one comparing rilpivirine FTC and TAF to continue the treatment that Elena was taking. And you see that while tenofovir is not a poison, the damage that was done was already done, and you see that the decrease is barely present. But what happened in those who started the TAF regimen, either in the study comparing the new regimen with TAF to rilpivirine FTC and tenofovir, or to efavirenz FTC and tenofovir, see the arm that switched to TAF showed an increase in the bone mineral density in all the district, hip and spine. And this reflects the study that was conducted, the 1089, just switching from tenofovir to TAF, and it's exactly the same thing. So what we obtain is obtained because of changing tenofovir to TAF. So the other possibility is to change to dual treatment. Dual treatment, the data that we have are with dolutegravir rilpivirine. These are the SWORD 1 and 2, and what will they look at the markers, the plasma marker of bone metabolism, and we saw that after the bone turnover, and we saw that we can see that after the switch, there is a decrease in the arm with the dolutegravir and rilpivirine in these markers of bone turnover. And this is that they have seen in the TANGO study that is the switch study with dolutegravir and 3-TC, also compared to continue a TAF-based ART. So you see that the osteocalcin, the bone-specific alkaline phosphatase, the procollagen, and the C-telopeptide collagen. So when I suggested her to choose between 2 and 3 drugs, asked her to choose between 2 and 3 drugs, she decided to go for 2 drugs. But for 2 drugs, is it everything clear about it? You know, she's very young, she is 43. We know that there is also the problem of chronic inflammation, and that HIV is now a chronic inflammatory disease. This is not a very good study, but it's the only one that we have for now. It's not very good because it's not on dolutegravir and 3TC, if only 56 patients were on dolutegravir 3TC. So this is the CoRIS cohort, is the Spanish cohort. They put together all those who were in monotherapy, dual therapy, and compare them to the triple therapy. And when they look at the risk of failure, it was higher, obviously, in monotherapy. But they also had a look at the plasma marker of inflammation. And it seemed like, for example, CRP was higher in the group dual therapy. So we have to understand a lot of things. We don't know what will be the effect of switching from 3 to 2 drugs on the chronic inflammation. For now, the results are very reassuring. So I really tell her that she could go on dual therapy, but I will monitor her. So what the EACS guidelines tell us about reducing risk of fracture, in this case of refracture, you know, because the problem is not only that, you know, we switch the treatment. She has to change her everyday life and go for a more healthy lifestyle. So we have to address the fall risk, and we have to continue osteoporosis screening. So with calcium, phosphorus, and alkaline phosphatase every 6-12 months. We have to do the fast risk assessment every 2 years, as consider DEXA screening every 2 years. And even after the switch, don't do the DEXA scan before 2 years because it doesn't make any sense. Ensure adequate intake of calcium and vitamin D. And, you know, sun exposition also. It's, you know, even if we are, I mean, I'm Italian, we have an important deficiency of vitamin D despite in our population, despite the fact that we are the country of the sun, but we are always in our offices, so the sun couldn't reach us. And consider bisphosphonate, as in this case, you know, we decided to go for bisphosphonate because the fracture, you know, really scared us. Okay. And we continue, as I said, to evaluate if she has to continue. Probably not, because we switched the treatment. And as I said, we told her that she has to walk or to run, because she's young enough also to run, but especially to walk, because it's important that she press with her weight on the ground in order to make the bone rearrange, you know. She should add vitamin D to the treatment, and in 2 years, as I said, she has to perform a new DEXA scan.